So welcome everybody to our web seminar for the NCHLDD network today. I'm really excited to see such a great turnout because we have some fantastic speakers, and these are folks who were some of our grantees, and today they're going to talk about the work that they've been doing with a small grant from the network. I'd like to introduce the two speakers whose names you already see on the slide and probably whose names account for why we have such a robust group. I know we're really all excited to hear from them. Taylor Hargrove is an assistant professor of sociology at UNC Chapel Hill and completed a PhD at Vanderbilt, working in the areas of race and ethnicity, medical sociology, life course and aging, stratification of health, and quantitative methodology, and has many fascinating publications and projects, and we're going to hear about one strand of those today. I just wanted to also highlight that Taylor won the Matilda White Riley Early Stage Investigator Paper Award from NIH, from the OBSSR, and I know that there is a deadline soon or coming soon for that paper award nomination. So I just want to give you a shout out, Taylor, and see if anybody else, don't forget to nominate folks for those. Those are really important. And Lauren Gaydosh is also known to many of us as an assistant professor of sociology at UT Austin, and was just revealing to us that my 0-degree weather out here can't compete with 80 degrees in Austin today. Lauren is currently in the Department of Sociology, but previously was at Vanderbilt in the Departments of Medicine, Health and Society, and Public Policy and Sociology, and was a postdoc, an NIH postdoc prior to that at UNC Chapel Hill, and did a PhD at Princeton in sociology, demography, space. These two really accomplished scholars have published a lot together, and so I just was looking through their CVs, and I just noticed a really cool paper that came out about a year and a half ago in the American Journal of Public Health with another of the folks on the call today, Bob Hummer, and potentially other people on the call, entitled "The Depths of Despair Among U.S. Adults Entering Midlife." And they've done a lot of really important work with the ad health cohort and other cohorts around health disparities and social determinants that I think are really relevant for this group. So I'm really excited to have them speaking for us today. The format that Lauren and Taylor have laid out for us is that they'll be tag teaming on this presentation and are willing to take questions along the way. There are some natural stopping points at which it would be a good time, if you have questions, to pipe up, and so you can put those in the chat at any time, but I'll kind of hold those for those stopping points, or we'll also give you some opportunities throughout and then at the end to ask your questions. So at this point, I'm going to turn it over to our esteemed speakers and let you take it away. Thanks very much.
Thanks so much, Sarah, for that very generous introduction of both myself and Lauren. And thank the network for having us here today. I think we're both very excited to talk with you all about what we've been doing and kind of what's still to come in terms of the merging contextual data onto the ad health study. And so here's just a quick outline of what we're hoping to get through today. First, just starting with a refresher on the existing contextual data that's available in ad health, as well as the new data that's being introduced. We'll talk a bit about the progress of the contextual data merges that we've led, some of the challenges working with contextual data, and then we'll present some results from an ongoing project that uses some of the new contextual data before talking about looking ahead for wave 6 of ad health. So as I'm sure a lot of you know, there's already a ton of contextual data already available in ad health. And the data come from several sources, including the census, the CDC, the FBI, the National Center for Health Statistics, as well as some other sources. And so this information is available at generally local levels, so county, neighborhoods, census tracts, and block groups, but also there's some state level information available as well. And so what we have basically is over 10,000 contextual variables across waves 1 and waves 4. So we have information spanning the years of 1994 to 2009. And these topics range from socioeconomic, demographic, epidemiologic, political, environmental factors, informational climate and pollution, et cetera. And so the data is available in several formats. There's a public use option available for waves 1 through 4, and it consists of half of the core sample and half of the oversample of African-American adolescents who had a parent with at least a college degree. And so overall, the public use data has about 1/3 of the total ad health sample. And with these data, you'll have access to some of the contextual information, but really only from waves 1 and 2, but it's not the complete information that could be available. And you can gain access to the public use data from ICPSR, the Association of Religion Data Archives, and the Odom Institute at UNC. There's also a restricted use data option. And with this, you would have access to all of the contextual files across all of the waves. This will require a contract with AdHealth, and it can take 6 to 8 weeks from the time you submit an application for that contract to when you actually get the data. So just something to keep in mind if you're thinking about using these data. And these contracts also require several things, including a signature from your institutional representative, a sensitive data security plan, a security pledge, IRB approval, and then if you are applying for a new contract, there would be a one-time fee. So in addition to this wealth of data, there's been several additions to the contextual database in AdHealth. And the motivation for this contextual data merge effort is really two-pronged. So the first was to facilitate consistency and harmonization of data across waves, especially in the level of geography. And then these efforts were also born out of a project by Lauren and myself that focuses on the relationships among SES, mobility, and health. And I'll discuss this project in more detail in just a second. So in terms of consistency and harmonization, we've led 2 updates to the AdHealth contextual database. The first is including information at the state and county level for wave 4. Previously, only tract level data was available. And then we've added information about the environments of respondents during their wave 5 interview at all 3 levels of geography. So the state level, county level, and tract level. And so the information available here is consistent with what is available at prior waves. So now we have the same measures of respondents surrounding contexts across all 5 waves of AdHealth, meaning that we know about respondents' environments across an almost 30-year span. And like I said before, the motivation for these efforts also stem from a funded R21 project that Lauren and I are leading. And so just to give a brief background about this project, there's been this growing literature documenting the health consequences of upward social mobility. More specifically, these studies are showing that upward mobility is associated with poor physiological health, particularly for Black Americans. And so the hypothesized mechanisms linking mobility to poor physical health have been individual level psychosocial factors and behavioral factors. So things like stressors, aspirations, expectations, behavioral dispositions. But we know less about the role of biological risk factors and the structural contexts in which mobility occurs. And so we are really interested in evaluating the social and biological mechanisms that underlie relationships between or among SES mobility and health among a diverse array of population subgroups. And so to do this, we propose to merge on additional data to the AdHealth study and begin to investigate the roles of inflammatory response, immune functioning, and importantly for the purposes of this talk, environmental incongruence, right? So the roles of these factors in linking upward social mobility to poor physical health. And what we mean by environmental incongruence is the degree of dissimilarity across environments of origin and destination, or more generally across the life course. And so given our hypotheses and the scope of the project, we identified 5 new sources of data to merge onto AdHealth listed here. So information from Opportunity Insights, the Institute for Health and Health Metrics and Evaluation, RWJF County Health Rankings, the Kaiser Family Foundation State Health Facts, and then tax burden on tobacco. So I'm going to hand it over to Lauren now.
Excellent. Thanks, Taylor. And thank you again to the network for having us and for supporting this work. And thank you everyone for joining. We're really excited to share these new data resources with you and hopefully, encourage you to start to dig into these data and work with them in your own research. So Taylor mentioned some of the new resources that we've added to Add Health. I'm going to focus on what exact variables we've added, just to give you a little bit more detail into what might be possible for your work, particularly in health and health across the life course. So we've added information from the tax burden on tobacco. So at all 4 waves, and forthcoming will be the 5th wave. At the state level, we have information there. From the Kaiser Family Foundation State Health Facts, we've added information at wave 5 at the state level. From the Institute for Health Metrics and Evaluation at waves 1 and 4, we've added information at the county level. The Robert Wood Johnson County Health Rankings are also available at waves 1 and 4 at the county level. And then from Opportunity Insights, which is the project, the sort of data resource project led by Raj Chetty and Nathaniel Hendren, we've added both county level and college level information about mobility at the county at waves 1 and 4, and at the college level at waves 3 and 4. And then we've also added additional data from iPads at the college level at wave 4. So let me go into a little bit about exactly what is in all of these data. From the tobacco tax information, we have state level cigarette tax per pack, so across waves 1 through 4. From the Kaiser Family Foundation, we were really interested in understanding the role of health insurance coverage. And so at wave 4 now, we have information at the state level in terms of different types of insurers and the % of the population that is covered from those. And we'll also talk about some additional information that we're adding to wave 5 around expansion of the Affordable Care Act. From the Institute for Health Metrics and Evaluation, we added a lot of information here at the county level in terms of health, mortality, morbidity, outcomes, and health behaviors. So there's information on life expectancy at birth and age-specific mortality rates, both by sex and for total population. There's information on diabetes prevalence, awareness, and control, also both by sex and for total population. There's really interesting information on health behavior, so alcohol use and binge drinking, as well as smoking status. And then information as well on obesity prevalence and rates of physical activity. So these are really exciting data that can help you understand the sort of health climate and culture of particular places. From the Robert Wood Johnson Foundation, we've added in their county health rankings. And for those who are not familiar with these health rankings, they're sort of an aggregation of a lot of different types of measures of health at the county level. And so we've added in their outcome ranking quartile and their factor ranking quartile. The outcome focuses more on sort of different types of health outcomes, whereas health factors focuses more on different kinds of health behaviors influencing health outcomes. And as Taylor mentioned, our interest in this contextual data merge was really born out of a project interested on social mobility and health outcomes. So we've added information from the Opportunity Insights County mobility data. Here already available are relative and absolute mobility rates, as well as the causal effect estimates that Chetty and Hendren have produced. So this is the estimate of how much additional income a child could expect by spending another year in their county of birth, dependent on an adult household income at the 25th percentile. And then there are also income Gini coefficients at the county level. Also from Opportunity Insights, they've created these really fantastic college mobility report cards. And so this gives you a sense of how successful institutions are at promoting the access and upward mobility opportunities of their students. But it includes a wealth of information on the type of institution, the selectivity and the SAT scores, both parental and individual adult income of the individuals who attend these schools. Using that income information, we have the mobility rate for the college, the cost, things about their endowment and expenditures, graduation rates, student demographics, and the shares of different types of majors. I just want to note that this is really just a fortunate data circumstance for AdHealth, because the cohort on which these data were created by Chetty and Hendren match almost perfectly with the AdHealth cohort. And so it's a really nice opportunity to study college mobility, county mobility, using a data source that matches really perfectly with the AdHealth study. And we've also added information from IPEDS. This was already available at Wave 3, but now we've extended this to include Wave 4. So for the institution from which an AdHealth participant received their bachelor's degree, we have information on the type of institution, the cost, again, some measures of sort of selectivity, size, student demographics, as well as different kinds of academic and professional services that are provided at the university. And finally, under the motivation that Taylor mentioned of harmonizing data across the waves, what we have also done is now create a new grouping ID, which essentially allows users to conduct longitudinal analysis by geography over the waves. So previously, the geographic identifiers were not consistent across the waves. And so now there is a new grouping ID so that you can conduct sort of longitudinal analysis looking at change in places over time. Excellent. Oh, Taylor, you are muted.
Sorry.
You're good.
Thank you. So as you can probably tell from what Lauren's been saying, there's already a lot of new data available, new contextual data available for use right now, but there's still more to come. So hopefully in the next couple months, we should be releasing updates to the Wave 4 contextual data at the state and county levels, as well as all the contextual data in Wave 5. So kind of the traditional sources, the ACS, the Climate Atlas, Uniform Crime Report, and RUCA codes, as well as information from these new sources of data that Lauren described. So from Opportunity Insights, IHME, RWJF, et cetera. And also, as Lauren mentioned, there'll be some data from the ACA, the Affordable Care Act, in terms of the year that ACA Medicaid expansion, there was Medicaid expansion. Also coming are additional measures from Opportunity Insights that became available after our first round of merges. So these measures will be merged on to respondents' location at waves 1, 4, and 5. And they include different mobility indicators by social characteristics. So absolute mobility by race, gender, and maternal nativity status, the probability of reaching the top 1% of the income distribution by race and ethnicity, and then the probability of living in a census tract with a poverty rate of less than 10% by race and ethnicity.
Thanks, Taylor. So we wanted to highlight also just some of the challenges involved in doing this kind of contextual data merging and work. You know, the network has been incredibly supportive, and we've learned a lot from other network members about how to do this efficiently. And we're trying to coordinate across studies so that we're not duplicating efforts. But just to give you a sense, this is one example of a data merge, including information from the American Community Study. So first, you kind of have to get the data from the source, import it and process the text, create labels for all of the data, identify any variables, and calculate any sort of constructed information that you want, and repeat that for 56 different tables. At that point, then we have 754 variables from the contextual data, and we're merging it onto census tract and counties, census tracts, counties, and states for the AdHealth participants. And then we also have to, in a secure facility, assign these tracts and counties to all respondents with geocoded data in, as I mentioned, this secure facility, protecting the identity of our respondents, and match all respondents to all contextual measures. So those are some of the challenges involved with just the processing of the data. But then there are also a lot of challenges involved with dissemination of this kind of data. So we take very seriously the risk of deductive disclosure. So all of the data, you might see some sort of differences between the data that are in AdHealth and the original source data in terms of the level of granularity or collapsing of different categories. This is because of the risk of deductive disclosure. So the AdHealth data team analyzes everything that we've merged to make sure that that's not a problem. Then we create documentation and release the data, disseminating it to users. And as Taylor mentioned, one of the sort of ongoing challenges is just what's involved in updating. So she mentioned that after we put this proposal together and did our first round of contextual data merge, the Opportunity Insights folks came out with tremendous new data, right? Race and ethnicity specific mobility rates. And so it's very exciting when all of these new data come out, but it's also very challenging to stay up to date and think about how then we need to maintain consistency across the waves. So if there's new data that come out, do we go back and sort of merge it retrospectively as well, right? Back to wave one of AdHealth. And then there's also the challenge of sort of changing identifiers and changing boundaries. So, you know, census boundaries changing, different counties merging or splitting, and all of these things can be really challenging in terms of merging contextual data.
So I think this might be a good place to stop and see if we have any questions so far.
I'm not seeing any in the chat yet, but I'm definitely monitoring those. Or if people have questions, you can signal to us. Kathy, is it possible for people to unmute themselves?
I'm sorry, Sarah. I think they can, but they can also ask to be unmuted.
Okay.
And I can do that.
Great. Well, in the interim, I do have kind of a small, potentially in the weeds question, but I'm curious about how you guys are thinking about deductive disclosure. And, you know, I'm interested in a look behind the curtain, like how do you actually make those specific decisions? Can you think of a generic example of the kind of thing that happens that you have to make those decisions for? And is there any basic set of guiding principles that you're working with that are agreed upon across folks that are doing this work, or do you have to kind of wing it?
I can start with this. So I think, you know, AdHealth has their own protocol when it comes to making sure there are no risks for disclosure of respondents. And I think part of that has to do with the amount of respondents in a given county or at a given locale. And so if there's too few, I forget I think there's a standard number or percentage, a minimum number or percentage that there has to be in that particular locale to be able to have that data released.
I think it's less than 10 or something like that in terms of cell count. And so to answer another part of Sarah's question about what are sort of established practices, one approach that AdHealth has taken and we have taken with these data is to divide things into sort of percentiles or quartiles or something like that, where the absolute raw values are masked, but you still get a sense of where people are in the distribution. So that is, I think, a practice that is pretty common in terms of releasing these types of data.
And it might be better than grouping data if it had to be across really large boundaries or time or something that would really make the data less valuable. I have a question. So it looks like Whitney Robinson has a question.
Hi, I had a question about timing. And so I can imagine that there's some contextual variables where you're trying to decide, is it relevant to a particular life stage or more relevant to a particular secular period? And you kind of referenced that with the CHLDD data that is really about kind of life course trajectories. And it seemed like that's built following the same cohorts over time. And it happens to match this cohort, which is great. But did you have any other instances where contextual variable, it was just a little bit unclear how to match it to the AdHealth cohort based on kind of age and calendar time?
Yeah, so I definitely recall specifically with the Institute for Health Metrics data that there was several years on either side of wave 4 timing. So that was 2008, 2009. And there's some data from the IHME that, were constructed in like 2012 or something like that. So we tried to make the best decision about what wave the contextual data are most relevant for in that sense. But it's certainly challenging. And in instances where there are sort of very large differences between the date of the source and the date of the Ad Health survey, we kind of make that known. And then I think we'll talk a little bit about this when we talk about our plans for wave 6 and some things that we're thinking about. But I think there's been some really exciting research coming out showing the continuing influence of sort of historical patterns. So things like redlining, and I know Hedy Lee presented some work at UNC on lynchings. And so thinking about how that kind of historical context is still relevant for our contemporary cohorts.
Helpful. Thank you very much.
Thanks, Whitney.
So there's another question in the chat, and this is from Patricia Homan. She's wondering, is there an email listserv or some way we can sign up to be notified anytime new contextual data is made available? And she made a comment, there is so much exciting data that you are planning to add.
Thanks, Trish. I think there's an announcement of the new release of data over the Ad Health listserv. So if you have a current contract with Ad Health, you should be on that listserv. If not, I think the best plan of action would be to contact Sarah Dean, one of the project managers, and she can get you on that listserv.
Yeah, I think also Ad Health is, pretty active on Twitter now as well in terms of publicizing research that comes out of the project as well as new data releases. So I would follow Ad Health on Twitter. I think they announce often when these data come out. And then we can also always sort of consider additional ways of data dissemination and user communication. So if there's sufficient interest, I think, in just specifically contextual data, I could see us creating a listserv specifically for that.
Great, thanks so much.
Thanks, Trish.
Looks like we're out of questions at this point, so I'll let y'all take back over.
Okay, so now we're going to talk about some results using some of the new data that we've merged onto Ad Health. So just to set the stage, with this particular paper, we're seeking to interrogate the robust educational gradients in health and mortality that have been extensively documented. And so there's been accumulating evidence that the educational gradient in health differs across racial, ethnic, and nativity groups. So specifically, prior work has demonstrated that higher education has a muted or non-significant effect on health for Blacks, and that several Hispanic and immigrant subgroups tend to have better health outcomes than their white and native-born counterparts, despite tending to have lower levels of educational attainment. And so as I alluded to before, talking about Lauren and I's R21, the types of explanations for these inconsistent relationships, or what some would call paradoxical relationships between educational attainment and health, focus on more individual level psychosocial or behavioral mechanisms. So specifically, a lot of scholars will discuss the increased exposure to interpersonal discrimination at higher levels of socioeconomic status, as well as different psychosocial resources, such as John Henryism or goal-striving stress, that have been developed in response to the stressors of navigating higher educational environments, particularly among those from disadvantaged backgrounds. And so while this prior work has been extremely important and informative, there's still a missing focus on the extent to which characteristics of the environments in which individuals begin and navigate their educational careers might enhance or attenuate the protective effects of educational attainment on health, particularly among different racial, ethnic, and nativity groups. So there's been some great work on the influence of state level contexts on educational disparities and health and mortality by some of our very own members of the network. So Jennifer Montez, Mark Hayward, Stephen Wolf, just to name a few. But we don't know that as much about the role of smaller geographic localities that are experienced early in life, right? When educational trajectories begin and are being shaped by a host of different factors. And so this is where our study comes in. We investigate whether and how various aspects of early life counties, namely the economic, policy, and social characteristics of childhood and adolescent counties, shape the education-health relationship for various race, ethnic, and nativity groups. And we focus on early life counties for several reasons, really taking a life course perspective. So one reason being that early life environments can set or shape trajectories of strain or stress that's experienced across one's educational career. So thinking about the accumulation of risk and resources that is spearheaded by or set by one's early life environment. And then another important reason has to do with the role of early life environments and the development of behavioral responses to stressors and the development of lifestyle choices. So we can think about how characteristics of early life counties might create specific types of cultures that residents are subject to, and that might shape the type of student an individual becomes throughout their educational career, right? So how they approach or address obstacles in schooling, right? So if individuals are exposed to certain early county cultures, that might differentially shape the need for these residents to develop lifelong strategies, both psychological and behavioral, for dealing with the stresses, strains, and opportunities of educational attainment. And so just, taking all this information together, we argue that there's a need to know whether and how characteristics of early life environments influence the effect of education on health and early adulthood, excuse me. So this paper seeks to contribute to this need by asking if educational disparities in cardiometabolic risk vary by race, ethnic, and nativity statuses among young adults. And then to what extent do economic, policy, and social characteristics of early life counties shape the education-health relationship for various race, ethnic, and nativity groups? So not surprisingly, right, we use data from AdHealth, specifically information from waves 1 and 4, as well as information from the American Community Survey and Opportunity Insights. We focus on Black, Hispanic, and white young adults, giving us a sample size of just over 13,000. Like I mentioned just a second ago, our outcome is cardiometabolic risk, which is a summary measure of health risk taken from wave 4 of the AdHealth study. So it's comprised of 7 physiological indicators, including waist circumference, triglycerides, HDL and LDL cholesterol, hemoglobin, blood pressure, and C-reactive protein. And so a continuous risk score is constructed by creating binary measures of each biomarker based on predefined disease risk cut points. And then we sum these binary measures and get an index ranging from 0 to 7. Our predictors of interest are educational attainment by wave 4. We dichotomize it into whether the respondent has a college degree or more versus less than a college degree. And then of course, we take race and ethnicity and nativity from waves 1, so non-Hispanic, Black or African-American, Hispanic and non-Hispanic white, and then whether the respondent was born outside of the US. So these are the characteristics of wave 1 counties that we focus on. In terms of economic characteristics, we include absolute mobility and income inequality, both of which are taken from the Opportunity Insights data. And so the absolute mobility measure gives us an idea of the expected rank of children from families who come from children of families at the bottom of the national parent income distribution. So higher values on this measure would indicate that an individual is growing up in a county or living in a county that has greater absolute mobility or greater economic opportunity. And then the Gini coefficient indicates the amount of parental income inequality at the county level. And another economic characteristic that we examine is the proportion of residents who are unemployed. So a proportion of residents in the county who are unemployed, and that's taken from the census, the 1990 census. In terms of policy characteristics, we investigate per capita direct expenditure on education and health and hospitals. And then in terms of social characteristics, we assess these with the proportion of county residents with less than a high school diploma or equivalency. And these latter characteristics are also taken from the 1990 census. Each of these county measures are dichotomized at race ethnic specific 75th percentiles in order to capture environments with high levels of potential mobility, high degrees of investments from county governments, and as well as significantly different meanings of education. So we ran 2 sets of Poisson regressions. The first set examining racial, ethnic, and nativity differences and the relationship between education and health. And then the second set estimating the education-health relationship by county level characteristics. So again, because they're dichotomized, we have these high and low categories. All of our models are stratified by race and ethnicity and nativity, and they control for individual, family, and school level characteristics. The results. What we're looking at here are plots of predicted CMR scores by race, ethnicity, and nativity, as well as by educational attainment. And what we're seeing is that for almost all of the groups, so whites and Hispanics, regardless of race, regardless of nativity, higher educational attainment, so these green looking bars, translates into lower predicted cardiometabolic scores. And so while we see a similar pattern among Black young adults, this actually doesn't reach the threshold for statistical significance, right? So these results suggest that relatives to some of the other groups, Blacks with high levels of education don't experience an equivalent benefit of education for health. So next I'm going to show you a series of plots that summarize results examining the education-health relationship further stratified by county characteristics for each racial, ethnic, nativity group. And so just to quickly explain what you're looking at here, I know it might be a little overwhelming. This is a plot of the predicted cardiometabolic scores for white young adults by educational attainment and county context. So the triangles are those white respondents who do not have a college degree, and the circles are those with a college degree or more. And then I don't know if you can see this well or not, but the letters within the shapes are either an H or an L. And so H stands for those who are living in counties that are high on a given characteristic, so above the 75th percentile, and L is the low group, or those living in counties that are low on a given characteristic. And then we have predicted CMR on the y-axis and just a labeling of the county characteristics across the columns. And just for ease of understanding this plot, we would expect the circles to be lower than the triangles, right? Because that would indicate lower cardiometabolic scores among those with higher levels of education. And so we're seeing this for white young adults, right? Across most of these counties, whites with higher education have significantly lower CMR scores than their counterparts with lower levels of educational attainment, regardless of the context that they live in during adolescence and childhood. There are 2 exceptions. So the educational disparity isn't significant among those who grew up in counties with high absolute mobility, high levels of absolute mobility, as well as high per capita spending on health. So this group here. So this is the same plot, but for Black young adults. And we're seeing something a little different. So there's only a significant educational disparity observed for those who lived in counties that facilitate mobility or socioeconomic achievement, invest more in their residents, and whose residents also have higher levels of education. So specifically, Black respondents who achieved a college degree or more have lower levels of CMR than their lower educated counterparts when living in counties characterized by high levels of absolute mobility, low proportions of unemployed residents, high per capita spending on health, and then low proportions of residents with less than a high school diploma. And we see a similar pattern for US-born Hispanics, right? Similar in some ways, in that a significant educational disparity is observed among those living in high mobility counties, counties with low proportions of unemployed residents, low levels of income inequality, high per capita spending on health, and low proportions of low educated residents. However, unlike Black young adults, higher education translates into better health for those growing up in counties with both high and low levels of unemployment, as well as both high and low levels of, high and low proportions of residents with less than a high school diploma. And then lastly, this is the plot for foreign-born Hispanics, who exhibit a pretty different pattern than for US-born Hispanics and Black young adults. So for foreign-born Hispanics, the educational disparities tend to be concentrated among those who lived in counties that constrain mobility or potentially hinder socioeconomic achievement, as well as counties that don't invest as much in their residents. So specifically, we're seeing higher education being associated with better health in counties with low levels of absolute mobility, high proportions of unemployed residents, high levels of income inequality, low per capita spending on education, and high proportions of residents with less than a high school diploma. There is one exception, and that results indicated that there is a significant educational disparity among those raised in counties with high per capita spending on health. So just to sum up what we found, it's a lot of results to sift through. First, the educational disparities are generally robust for whites. So higher education was associated with better health regardless of the early life context of white young adults, with just those two exceptions. But for racial and ethnic minorities, the educational disparity depended on the characteristics of the county, right? So for US-born Blacks and US-born Hispanics, to a certain degree, higher education was associated with better health, primarily among those who lived in advantaged counties as adolescents, right? And so what this means is that those who were living in disadvantaged counties didn't really see any kind of health benefit of higher educational attainment. So these patterns might suggest that living in counties that provide more advantages and support residents could ease the educational attainment process for US-born Blacks and Hispanics. For foreign-born Hispanics, we saw the opposite pattern, being that higher education was associated with better health only among those living in relatively disadvantaged counties as adolescents. And so these findings are suggesting that individuals, foreign-born Hispanic individuals, only experience a health improvement if they are upwardly mobile of sorts, right? So attaining higher levels of education despite living in lower resourced counties as children and adolescents. So I will stop there and kick it back over to Lauren, who'll talk about moving forward with Wave 6.
Great. Before I move into Wave 6, I just want to pause and see if anyone has questions about the results that Taylor shared.
I guess since I'm not hearing any at this point, let me jump in. It's my host's privilege. One of my questions is, how do you interpret the findings? It's important to think about how exactly to interpret the findings because the cut points are group specific, right? So they're the cut points at which things are high or low are not the same. And obviously you've stratified all the results, and you can sort of talk about it in terms of the relative disadvantage is the same, right? Because you're talking about a race or nativity specific disadvantage level. But I'm just curious how different those cut points are across groups, and whether that influences the way we think about the differences you just talked about.
Yeah, so thank you for bringing up that point, because they are different, right? So as we could probably predict, the percentages, the variation in these measures is greater among white young adults than they are among Blacks and Hispanics. So we ran these same results looking at absolute differences, so not race-specific cut points, and the results were the same. So even when the definitions of what a low and high county context was differed, it was still the same types of patterns where we're seeing the effects of education on health being contingent upon early life environments, particularly for Blacks and Hispanics.
And putting it into a race-specific context makes sense, probably just in terms of a power issue because of the differential segregation of different groups. So I just wanted to understand a little bit about how you thought about it and how you decided to do that. That's really helpful.
No, absolutely. And I think the other part of it is figuring out the appropriate reference group. So here we're really thinking about those who are growing up in similar environments, but are going on to attain different levels of education. Thanks for that question.
I'm not seeing any at this point. I think probably a lot of us are still percolating through. That was, the rainbows were really fascinating and contained lots of information. So I think everybody can keep percolating until after this section.
Great. Thank you.
Excellent, thanks. Okay, so we're really excited to be here today, particularly because we're starting to think about wave 6 of Ad Health. And Taylor and I are leading the contextual data effort in wave 6 of Ad Health, and we would really just like to get some of your feedback and your expertise and your thoughts about what you would love to see, added to the project. So at wave 6, respondents will be in their 40s. It's roughly going to be the period from 2022 to 2025. And so thinking about those things, we're starting to consider what are some of the other relevant social contexts for this period of the life course. So in particular, we haven't to date really focused on workplace environments as a contextual setting. And so we'd love to hear people's thoughts about how we might creatively use data to infer things about the places in which people are working. So thinking about, racial composition of different kinds of industries or occupations, or gender specifically, right? Or other creative ways to think about workplace environments. This is also going to be the period in the life course where individuals are facing sort of competing demands on their time and care for particularly older parents and younger children. So really thinking about what kinds of family policies might be important to consider both at the state and local level. So these are some of the relevant contexts that we're starting to think about, but we'd love to hear your thoughts. Also, sort of, undeniably, there's really important information now about the coronavirus pandemic and the sort of shape of the pandemic's trajectory across localities. So we'd be interested in including information on different policy responses, prevalence, kind of the burden of the pandemic in certain places, the pace, and now, importantly, the vaccine rollout, as well as different disparities in the coronavirus pandemic. One priority that we have as well for wave 6 contextual data is to incorporate more measures of structural racism and sexism. So thinking here, thanks Trish for the question. I see she's celebrating. Really drawing on your wonderful work as well as Tyson's work and others, thinking about how we can create new measures to capture these really important dimensions. So underrepresentation in the legislature, disproportionate disenfranchisement, differences in incarceration, immigration enforcement, so information from ICE on detentions, arrests, and removals, restrictive immigration policies. To Whitney's question earlier, we're thinking about historical sources of information that are still very relevant for our contemporary sort of disparities that we observe. So historical information on redlining and lynchings, and police brutality and police-involved killings. So these are some of the sort of sources of information that we've started to aggregate and think about, but we'd love to hear more about what ideas you have. And so specifically to that, we're really going to be soliciting in the future the input and advice of the network members. So please stay tuned and start brainstorming. You know, if you see a really interesting data set in the presentation, maybe shoot us an email or write it down, and we'll come to you soon in the future to get your input. Excellent. So that is what we have prepared for you today. We're really looking forward to discussion. This research was supported from, as Taylor mentioned, an R21, as well as the generous support of this network and the research support that AdHealth has received across the many years.
Thanks so much, Lauren and Taylor. Absolutely fascinating. I am monitoring the chat and don't see new questions, but Melissa said that she's excited to read the paper about the analysis that was just presented. And I think I speak for the rest of us that we would too. Do other folks have questions about the new additions? While we're waiting, I actually had a question or a thought about the occupation work characteristics piece, just because this is something I'm particularly interested in.
I was hoping you would.
Wondering if, like, what your starting points were. I mean, obviously you can think about sort of the occupation and industry mix of available jobs in the region and the likelihood that folks are going to be able to find good paying jobs or healthy jobs in a particular kind of commuting zone. And I think you could probably also look a little bit at the sort of, I'm not sure what level of geography you could get down to, but the demographic makeup of workers in those occupations in particular, so that you could kind of understand. Because I think, you know, a lot of occupations, the national data on sort of whether it's female dominated or the fraction of minority folks that tend to be hired into those positions is pretty good and applies to lots of regions, but I'd have to dig a little to see how sort of what granularity you could get the demographic makeup of the workers. There's also data on plant closures and unemployment rates at the local level, which doesn't get at working conditions, but does get at the instability of employment and unemployment. And I'll dig some more, but I mean, those are the two directions that immediately occur to me that would be sort of nationally available, and you might be able to get some interesting traction in the initial space. But I would definitely talk to Jennifer Montez, who unfortunately is, I think, on study section today. So it looks like Liz Lawrence has a question. Liz, do you want to hop in, or do you want me to read it?
I can hop in. Hopefully my dog will be quiet. I just was wondering about sort of healthcare provider institutions, and you know, I live in a place where it's really hard to find a doctor, so that and older adults for their parents. Sorry, my dog.
And your dog agrees. This is a serious problem.
We haven't added under the work that we have done any information about providers. I think this is a great point. Yeah.
And
I think, oh, go ahead, Taylor, sorry.
I do think there's information, I mean, it's from the census of just like the proportion of hospital and medical facilities in the, at the county level and tract level. But I do think, you know, that would be something to consider as well. As Lauren mentioned, you know, the respondents in Wave 6 are kind of going to be the sandwich generation, right? Where they're raising kids, but also could be the primary caretakers of their aging parents. And so I think the availability and the quality of medical facilities will become increasingly important.
Looks like Shannon said, this is phenomenal work. Thank you for your efforts with these data. And I would totally agree.
Thanks, Shannon.
And Whitney had a question. I don't know, Whitney, if you wanted to hop in.
Yeah, especially since my question was so mangled, sorry. I didn't know, in thinking about kind of economic opportunity in different areas, I didn't know if there was anything on medical bankruptcy rates or out-of-pocket healthcare spending. I imagine, especially with the patchwork of healthcare in the US, that there perhaps is a lot of variation in kind of that as a force to determine people's economic stability.
It's a great suggestion. Yeah, we don't have any information about that. So, you know, the closest we come to is kind of insurance coverage with the percent of the population that is uninsured. But do you know, Whitney, of any data sources offhand that would include this kind of information?
I bet Kaiser, Family Foundation Health News, or Robert Wood Johnson would have something or know where to go.
Excellent. We'll definitely take a look.
Absolutely. So Andrew popped in and says, this is incredible work. Maybe this is outside your scope, but I'm curious whether this is an opportunity to link to other non-contextual data sources to add health. And I don't know, Andrew, if you wanted to expand on that at all, or what kinds of other things you were thinking about?
Yeah, I guess maybe I hadn't thought too much about what those other sources would be, other than things like program participation, or potentially medical records. Yeah, I just think that getting over the hump with getting participants to agree to have their data linked is the hard part, and then once you do that, I mean, it sort of opens up a door. And obviously, you only have a limited time to pull this off and a limited amount of funding, but maybe there's an opportunity in the future.
Yeah, excellent. That's a great suggestion. I don't know, Bob, if you wanted to jump in here. I think that there might be plans in Wave 6 about administrative data linkages, so I don't want to speak to that.
Sure. Thank you, Andy. Yes, we have so many plans and such limited time, and you know, I will. So yeah, we'll be asking, you know, and I support, of course, asking folks for additional kinds of administrative linkages, and some do consent and others don't. Over a number of years now, we've been collecting death records for one, and we'll be releasing that data in the next few months. I'm not sure exactly when, but they're coming. We've been collecting birth records as well, and that's a very slow process. It's state by state, and each state is different, and they're fussy and difficult. But we will be releasing some birth record data in the coming months, year. I'm not exactly sure when, but we're getting there. But some of the other linkages that you mentioned, you know, that once we get consent and for and then we're able to, you know, folks can write ancillary study applications to link other data to EdHealth, you know, using funding that they bring with them. That's always a possibility. So you know, the biggest things are the consent processes, the ideas, the funding to do that work. And so we're open to all these kind of things, and we keep chipping away. So if you got a good idea, stay in touch with me, Taylor, Lauren, and we'll talk and kind of push things forward that make sense for us.
Yeah, I will add that one idea that we've been looking into is merging records with the student tracker database from the National Student Clearinghouse. So this would be information on sort of educational trajectories, much more specific than what we currently have from the participants, which is often just like what is the highest level of education and maybe what year they completed their degrees. So this would kind of show the pacing, dropping in and out of school, maybe some information on debt. So that's another source that's not really contextual, but is a possibility for linkage.
Thanks, everybody. Jess has asked, very interesting. Would transportation-related measures be of interest? For example, walkability, access to public transportation, etc.
Yeah, I think this is a great idea. I think Jess's partner also works in transportation, so I'm gonna maybe ask him to help us find some good data sources here. I think that there is already some information about like built environment, green space, those kinds of measures, but I'm not sure about like public transportation. So this is a really great suggestion.
It would even be cool if there's some kind of data source about the cost of public transportation to think about any kind of additional burden. You know, we know public transportation isn't always free for people. And, you know, there are certain areas, there are geographic variations in public transportation use as well. So we think about New York, how everyone takes the subway versus I can imagine in Wyoming, though I've never been, there's less kind of traffic with, not literal traffic, but in terms of how many people are taking public transportation.
Yeah, one of my colleagues has done a lot of work on thinking about transportation instability and creating an index for that to try to understand whether people have access to any kind of transportation, public or private. And you know, the costs of insurance in different regions and states and localities and maintaining a vehicle and all those kinds of things are an important part, but I'm not sure how granular you can get data on that, especially historically. But yeah, I think that the access to transportation is a major issue for folks in terms of wanting to be able to be employed distantly or taking care of family members or child kinds of moving around the city and so forth. So really great suggestion. There's a comment from Montserrat, very exciting, looking forward to the release of the death records. And there's also a question. Thank you for your fantastic work. Can you please explain more about harmonizing boundaries across waves? For example, are you harmonizing the 2000 census data into the 2010 census boundaries?
I do not, I'm gonna just admit I don't remember specifically which boundaries we harmonized into in creating this sort of cross wave identifier. But I believe that that's in the documentation. Yeah, that's a great question. The other context I think that we haven't really talked about at all, and is not where, you know, my work lies, but is thinking about sort of social media context. And, you know, Chris Bell's work around sort of Twitter sentiment and those kinds of measures that you can get at local levels. So yeah, I don't know if people are interested in those sorts of measures, but they arguably capture something about the climate in a lot of ways in different places.
How far back can you get those kinds of measures? I was actually wondering about that the other day with regard to trying to understand the experiential environments of different folks. So in terms of thinking about early life exposures for this cohort, maybe you can, or maybe not. I'm curious, sort of, obviously you could get it for the more contemporary periods, but.
Yeah, I'm not sure. I guess I know Twitter just announced some sort of research data that is available, I think more widely available than in the past, where there had to be some sort of agreement, I think, with the company, or you had to have some sort of in. But I would imagine that whatever they have released maybe goes to the start of the platform. I'm not quite sure, but again, that's not going to capture ad health in the 90s, right? It's quite a different time period. I also know that Raj Chetty is doing some work now about the sort of recession and the pandemic, aggregating consumer spending data and payroll data. And so we'll keep an eye on their work and the data that they make available, which is always really phenomenal and helpful. So those are other possible sources.
Do we have hope that we're going to get valid data on deaths and morbidity from COVID in small regions that will be valuable for thinking about current environments and sentiment?
I don't know.
Difficult time. It's valuable data.
Yeah.
So I'm not seeing any additional questions, but we definitely have time if folks have additional questions for our panelists, or if our panelists have the other things they'd like to ask the group.
I think it would be good just to get a sense of what you all would like to see. I know we've had some of that conversation already, but are there other domains we should be looking at, or ones that you're particularly excited about in terms of structural racism or sexism or the COVID context?
Yeah, Whitney just added excess mortality statistics will be valuable in terms of thinking about COVID effects in a local space.
Mm-hmm.
Like we're not getting
I
any.
feel like this, Whitney, sorry, I just feel like it's so hard to know. Like I'm trying to imagine, okay, what is my life going to be like in 2023, 2024? What's going to be relevant? And it is, I think, also just an experiment in imagination to think about, okay, like what's going to be the most relevant. And, you know, I always say I'm in this age cohort, so I'm always fascinated by it. Yeah, so that's not a solution, but just encouragement to be bold and creative, and some things will end up being super important, and some things will be like, oh, why did we waste time collecting that? Because it's just hard to know. It's a little bit of a guess.
Certainly the case. Andy added policy adoptions beyond ACA, which I think there have been a lot of changes and presidential changes in certain kinds of policies and actions happening very recently that are going to potentially be useful instruments later. Looks like Carmen has a nice long one. Carmen, do you want to talk to the group, or do you want me to read it?
Can you all hear me? I can
Yeah.
speak. Okay.
Yeah.
Cool. Thanks, Lauren and Taylor. I enjoyed your presentation. My comment, it was just about if you might be interested in expanding your measures on the criminal legal system. It sounded like you were going to include measures of incarceration, but as someone who studies that system, like most people are involved through lower forms of punishment. So that might include community supervision, like probation and parole, but even more broadly and widely, people get caught up in the system through like fines and fees. And there are there's like at least one multi-state project that's completed that has these data at local levels for fines and fees that you might be able to add or expand for your study. So I just wanted to throw that out there and see if that was something you all might be interested in.
That's great. Absolutely. We know that, you know, there are stark disparities and geographic variations of those disparities. So I think that would be super important, especially, you know, like you were saying, getting measures or indicators of contact with the criminal justice system outside of just incarceration, because that's kind of the end of the process, and thinking about other types of events or policies that funnel individuals into contact with the criminal justice system. So thank you for that, Carmen.
I just put in a couple of links just to shout out to somebody at the Pop Study Center here at Michigan who has a big project called CJARS. It's a criminal justice data platform and has a lot of really pretty cool data. And even if Mike doesn't have the data, you know, at the levels and across all states, I think it would be really great to just chat with him about the kinds of stuff they're collecting, because it really does get down to the nitty-gritty of all the administrative data that's available. And there's a webinar, I just got an email about it. There's a webinar if other folks are interested in understanding how to use their platform coming up. There's a March 5th and a March 9th, so that link is in the chat. Liz put in a note, have we mentioned housing, evictions, affordable housing stock, etc.? Sorry, I had to step away for a moment, so I don't know if I missed it.
No, you did not miss it, Liz. I think that's a great suggestion. I know that the eviction lab at Princeton is assembling a really large data set of evictions. I'm not sure the coverage, So that's certainly something that is always challenging for us to keep in mind. As Sarah mentioned, right, some of these sources are only available in like particular metro areas, and because, you know, Ad Health is nationally representative, it's then hard to think about weighing the value of that information versus like coverage of the entire cohort. But I think that these are great possibilities and should definitely look into it.
Totally agree.
And Trish mentioned also measures of heterosexism, anti-LGBT policy and attitudes.
That's a great suggestion. I know that Wendy Manning, I think, and I'm forgetting the other person, did a contextual data merge recently that has some measures of this. That was like just recently released, I think, and definitely within the last year. But yeah, these are great suggestions.
Yes, I know that somebody had a specific grant to do the LGBT policy. I can't remember who it was. And so there is one or two waves I'm familiar with that has that data. And I've been actually working on a paper with that with some other folks. But I was just thinking like more broadly going forward to think about not only racism and sexism, but heterosexism as well. So I'm sure there'd be a lot of people interested in that too.
Yeah, that's a great suggestion.
So it looks like we're maybe wrapping up with the questions, and while we wait for any final questions from the floor, I just wanted to mention that this event today is a part of a series, and so I just want to give you a little sense of what's coming up. In a few weeks from now, we'll be doing round 2 of our grant mentoring program, where folks can submit an Ames page or parts of a grant for some specific feedback from our network members and PIs. So that's going on, already had the deadline, but we will plan to do that again in the future. And then March 5th is our next webinar, and that's going to be presented by Scott Burris with a tentative title of Legal Epidemiology and the Role of Law in Population Health. And I believe I saw Scott on the call today, so we're really excited to have you for that one. The registration link will be up soon. And then in April, on April 2nd, we'll be hearing from the pilot grant recipients for year 6, Jason Boardman, Courtney Bowen, Carmen, who's on the call and just asked a question, and Trish, as well as Adriana Reyes. And so that one also will be a link coming to you soon. And then our last presentation before the PAA festivities is April 23rd. We're going to have a methodology workshop on weighted index regression models for estimating neighborhood contextual effects. So obviously really relevant for the things that you might be wanting to do with these data, and that's going to be presented by David Wheeler. And so there's a link to register for that that's available in co-sponsorship with Syracuse, and you'll be getting information about that too on the normal channels. Does anybody else have anything they want to add, or our panelists at this point in the presentation?
I just want to thank everyone for their great ideas. It's given us a lot to think about. It's really, it's exciting to see all of the possibilities.
Well, we're just grateful to you for doing this incredible labor that's going to be of great benefit for the population health and science community. So kudos to you. I know a lot of people here are virtually clapping or celebrating, and we're so pleased to be a little bit of a part of it here in the network. And thanks everyone, regardless of what your weather is, whether it's 0 or 80. I wish you a good weekend and a safe weekend. And just, I'm grateful for a really stimulating conversation here at the close of a long week. So thanks everybody.
Thank you so much.